So what is a pneumothorax? A pneumothorax is basically a collapsed lung. It's an abnormal collection of air between the lung and chest wall called the pleural space. This X-ray shows an example of a right-sided pneumothorax. The arrow is pointing to the border of the right lung. Notice how there's an absence of lung markings from that lung border to the chest wall. This indicates that there's a pneumothorax present. There are several different types of pneumothoraces. One type is a spontaneous pneumothorax. This is when there's a hole in the lung parenchyma or the tracheobronchial tree that leads to air leaking out into the pleural cavity. A spontaneous pneumothorax can either be primary or secondary. A primary pneumothorax occurs in a patient with no underlying lung disease. It's more common in males than females, and the patient tends to be a thin young adult. There are some hereditary conditions that can predispose a patient to a pneumothorax, and they include connective tissue disorders such as Marfan syndrome or Ehlers-Danlos. A secondary pneumothorax occurs in a patient with underlying lung disease. This includes things like COPD, asthma, cystic fibrosis, lung cancer, to name a few. The next type of pneumothorax is a traumatic pneumothorax. And this can be due to penetrating trauma like a gunshot wound or a stabbing, and this leads to external air coming into the pleural cavity. A traumatic pneumothorax can also be from blunt trauma, iatrogenic trauma, or blast injuries. The final type of pneumothorax is a tension pneumothorax. This could be from a spontaneous or traumatic pneumothorax. This is essentially when there's a one-way valve that allows air to enter the pleural space but not exit. This can cause the intrathoracic pressure to increase, and this can lead to an emergency. So what are the signs and symptoms to a pneumothorax? Patients usually complain of pleuritic chest pain and shortness of breath. They may also complain of cough and fever, but these are less common. Signs include tachycardia, tachypnea, and hypoxia. In the case of a tension pneumothorax, hypotension may be present as well. Remember, in a tension pneumothorax, we said this was essentially a one-way valve, and it might increase intrathoracic pressure. Well, this increased intrathoracic pressure can compress the heart and vasculature. It can compromise venous return back to the heart, which can decrease cardiac output and blood pressure. This is a form of obstructive shock. The patient may also have tracheal deviation toward the unaffected side, as we see in the image. Lastly, the patient might have jugular venous distension from all that increased intrathoracic pressure. So what are some different ways we can diagnose a pneumothorax? We already know from before that a chest X-ray can show one. A CT chest is not always necessary, but it is more accurate in picking up some of those smaller pneumothoraces. It may also be necessary to better evaluate for any underlying lung pathology. And if you're good with ultrasound, you could do a thoracic ultrasound. A lack of lung sliding could suggest a pneumothorax. And if you put it on M mode, a normal lung will show a sandy beach appearance, whereas a pneumothorax might show a barcode sign. Lastly, we're going to talk about some different ways to treat a pneumothorax. First, I will caution you on intubating the patient. Obviously, if the patient requires intubation, then do so. But remember, by intubating the patient and putting him on mechanical ventilation, you're going to be increasing that intrathoracic pressure even more, and that could worsen things. Nearly every patient with a pneumothorax should be receiving supplemental oxygen. The reason for this is 100% oxygen administration increases the rate of pleural air reabsorption. In cases of a small primary pneumothorax in which the patient is fairly asymptomatic, just giving them supplemental oxygen might be adequate enough. Observe them and reassess them, and if their symptoms are improved and a repeat chest X-ray shows improvement of that pneumothorax, they may not require hospital admission. However, if it's a large primary pneumothorax or the patient's really symptomatic, or for most secondary and traumatic pneumothoraces, the patient may require a chest tube. And there's an example image here of a right-sided chest tube. It should go in the 4th or 5th intercostal space, mid to anterior axillary line. In cases of a tension pneumothorax, or if the patient's unstable, you may need to consider a needle decompression in that 2nd intercostal space mid-clavicular line. Lastly, if the patient has a persistent air leak or recurrent pneumothoraces, they may require some sort of surgical intervention. One example is a pleurodesis in which the visceral and parietal pleural layers are attached together.